Tachycardia. For practical purposes, it is easiest to divide tachyarrhythmias into atrial tachycardia, atrial fibrillation or atrial flutter, atrioventricular nodal reentry tachycardia, of right, and atrioventricular reentry tachycardia, AVRT. Ventricular tachycardia, VT. Etiology and epidemiology. Atrial tachycardia. Atrial tachycardia is caused by an ectopic source of atrial tissue firing in a rhythmical manner faster than the sinus node. It is a rare cause of tachycardia. On an ECG it may look similar to sinus tachycardia but with abnormal P-wave morphology. Atrial fibrillation and flutter. Atrial fibrillation affects 0.4% of the whole population, rising to 2.4% in people over 60 years old and greater than 11% in those over 75 years old. Its causes are numerous. Hypertension, ischemic heart disease, congestive heart failure, valvular heart disease, thyroid dysfunction, pulmonary abnormalities, e.g. pulmonary embolism, pericardial disease. Right and AVRT. These are the result of the presence of an additional conducting pathway, allowing a reentry mechanism. In most cases, the electrical impulse is conducted antegradally, atrium to ventricle, via the atrioventricular, AV, node and retrogradely through the accessory pathway, concealed accessory pathway. If conduction is in an antegrade direction through the pathway, e.g. Wolff-Parkinson-White syndrome, pre-excitation is seen on the surface ECG. Ventricular tachycardias. Almost any pathological process affecting the ventricles may predispose to VT. Myocardial infarction, acute or chronic. Dilated cardiomyopathy. Hypertrophic cardiomyopathy. Valvular heart disease, especially aortic stenosis and mitral prolapse. Hypertension. Congenital heart disease. Long QT syndrome. Cardiac tumors. Pathophysiology and pathology. Tachyarrhythmias occur as a result of abnormal automaticity, e.g. VT after myocardial infarction. Triggered activity, e.g. VT with long QT syndrome. Reentry, e.g. atrial fibrillation, AVRT, and right, VT, ventricular fibrillation. Clinical presentation. Common palpitations, presyncope or syncope, breathlessness, chest pain. Uncommon. Patients may complain only of lethargy. Rare. Thromboembolism is unusual, except in atrial fibrillation. Physical signs. Examination of sinus rhythm may be unremarkable. However, during tachycardia some physical signs may help to establish a diagnosis. Atrial fibrillation and flutter. For the physical signs of atrial fibrillation and atrial flutter, see Table 23. Right or AVRT. Physical signs are not especially helpful in making the diagnosis. Regular pulse. JVP may be raised, but waveform is normal. Constant intensity of first heart sound. Ventricular tachycardias. Patients may or may not be significantly compromised. Physical signs include hypotension, Cannon waves. Investigations. Investigations aim to exclude a structural thoracic and cardiac or metabolic cause. Aside from an ECG, CXR, echocardiogram, thyroid function tests, renal function, and electrolytes are appropriate in most cases. 12-lead ECG. Documenting the arrhythmia with a 12-lead ECG will, in most cases, establish the diagnosis. In some cases where there is evidence of pre-excitation, the diagnosis can be relatively confidently made in sinus rhythm. Distinguishing some arrhythmias can be difficult. Atrial flutter versus atrial fibrillation. Look for characteristic flutter waves, Figs 44 and 45. Right versus AVRT. Distinguishing these is rarely of clinical importance because, in most cases, management is similar, Fig 46. VT versus right or AVRT with aberrant. Ambulatory monitoring. Documentation of an infrequent rhythm may be possible using 24-hour Holter monitoring or patient-activated devices. Electrophysiological studies. Treatment. There are many different classifications of antiarrhythmic agents. The von Williams classification is the most commonly used and is based on the cellular action of the drug, Table 24. Emergency. Atrial tachycardia. Most patients will not be compromised. DC cardioversion or intravenous amiodarone will restore sinus rhythm in the majority. Atrial fibrillation and flutter. If the patient is compromised, consider DC cardioversion or intravenous amiodarone. Right or AVRT. Most will respond to intravenous adenosine. Verapamil may be used if you are confident that the rhythm is not VT. Ventricular tachycardias. Short-term. Atrial tachycardia. Consider the following. Class I agent, if structurally normal heart and no coronary disease. Beta blocker. Class III agent. Calcium antagonist. Atrial fibrillation and flutter. The main aim of treatment is the restoration of sinus rhythm. This may be achieved pharmacologically or electrically with DC cardioversion. In all cases, the risk of thromboembolism and the requirement to anticoagulate should be considered. Consider the following. Anticoagulation. DC cardioversion. Class III agent. Digoxin, rate control only. Class I agent, if no coronary artery disease. Right and AVRT. Consider the following. Class IA and IC agents. Class II, beta blockers. Class III, sotalol. Class IV, verapamil. Ventricular tachycardias. Consider the following. Class III agents. Class I agents. Class II agents. Temporary pacing may prevent VT in patients with bradycardia-induced VT or long QT syndrome. Long-term. Most short-term drugs may be used long-term, but more definitive therapies should be considered. Particular caution should be applied to committing any patient to long-term use of amiodarone. Its side effect profile is worse with chronic use. Atrial tachycardia. The focal origin of these arrhythmias makes them particularly suited to catheter ablation. Atrial fibrillation and flutter. Consider the following. Anticoagulation. Ablation for atrial flutter. Ablation for paroxysmal atrial fibrillation. Ablation of AV node and permanent pacemaker for atrial fibrillation not controlled with drugs. Right and AVRT consider ablation. Ventricular tachycardias. Consider referral for ablation or implantable cardioverter defibrillator. Complications. Atrial fibrillation and flutter. Thromboembolism is the most significant and devastating condition. Right and AVRT. Complications are uncommon, but with Wolff-Parkinson-White syndrome, rapid conduction of atrial fibrillation down an accessory pathway may precipitate ventricular fibrillation. Ventricular tachycardias. Hemodynamic collapse and death is a potential risk in many cases of VT. Prevention. Primary and secondary prevention of stroke and transient ischemic attack. NB. Cardioversion of atrial fibrillation and atrial flutter. The following can be used as guidelines for anticoagulation. Duration lesser than 48 hours, proceed without anticoagulation. Duration greater than 48 hours, anticoagulation for 4-6 weeks before cardioversion, and for 4 weeks afterwards. Duration greater than 48 hours and no evidence of intracardiac thrombus on transesophageal echocardiography, proceed without anticoagulation. Sinus rhythm is achieved in approximately 85% of cases of atrial fibrillation and atrial flutter, but recurrence rates may be high, up to 75% at 12 months.